So we're talking today on endoscope disinfection. Where do we stand in 2019? It's for sure scary stuff. Everything that we hear on the media, the one I particularly like is this one, which says legal help for victims of superbug outbreak, and it's actually, it says here, click here to start now. So for people who are a little bit further removed from the medical school, like I am, required a little bit of review about what are the superbugs. It's one of them is carbapenem-resistant Enterobacteriaceae. It's spread via oral fecal route. There's been an increase in number of cases, about threefold increase. The common organisms are Klebsiella pneumoniae, E. coli, and Enterobacter. CRE is just one of the superbugs. The other member of superbug family are vancomycin-resistant Enterococcus and MRSA. And CRE resistant to, some of them are actually pan-resistant and resistant to all major antibiotics, such as doripenem, entropenem, and imipenem. Some respond to older antibiotics like colistin and tigecycline. It's associated with 40 to 50% mortality, and the concern is that it could be easily spread, especially in patients who are moving between various hospitals, acute and subacute facilities, as depicted on the diagram. It also can have shared genetic material that contributes to spread. There are various mechanisms of resistance. Carbapenems are beta-lactam antibiotics. In the same group are penicillin and cephalosporins. There are enzymes like beta-lactamases that break down the antibiotics. There is also a mechanism for active removal of antibiotic from bacterial cell wall. Sometimes those porin mutations are combined with beta-lactamase hyperproduction, so kind of two hits. And then there's a potential for modification of bacterium target site. The good news is that they are not inherently resistant to high-level disinfection agents or the process. So what are the risk factors for CRE? Clearly, it's a prior treatment with carbapenems or other broad-spectrum antibiotics, ICU care, immunosuppression, patients who are elderly, and now duodenoscopes or endoscopes are another risk factor for CRE. Just as a reminder, endoscopes are considered to be semi-critical devices because they're common contact with mucosal membranes, and either sterilization or high-level disinfection are appropriate, and that should get rid of all organisms except for some bacterial spores. Alternatively, forceps would be considered a critical devices as they come in contact with sterile tissues. So how the disinfection should be done, high-level disinfection should be done. It starts in endoscopy room with a point of use pre-cleaning, and then move towards leak testing, manual cleaning, high-level disinfection or gas sterilization, followed by alcohol flush and air drying, followed by storage. The reminder that for Olympus equipment, we're required to use a special brush, and that is very critical to lift the elevator to at minimum 45 degrees and lift it and depress it several times during the process. There are multiple agents for high-level disinfection that are approved by FDA. The one that's commonly used is peracetic acid nowadays. The gas sterilization is a low-temperature sterilization. ATO is an alkylating agent. It disrupts the DNA and prevents the bacterial replication. However, it's quite a laborious process. It takes time, has 3 steps involved, and has could potentially injurious for the staff as well. Just going down the memory lane, major outbreaks, important to keep in mind that all three endoscopes from all three manufacturers have been involved, as well as various models. And various organisms, a number of patients. I believe the count is probably much higher nowadays. And I would go over some of those major outbreaks a little bit later in the talk in more detail. As a response to those outbreaks, FDA came out with several recommendations as well as communication warnings, and worked extensively with the industry and ordered the manufacturer to undergo several additional studies. As a result of that work, this is one of the major FDA communication from August of 2015, where combining with strict adherence to duodenoscope manufacturer processing instructions, the following supplemental measures were suggested to be used, and that include microbiological culturing, gas sterilization, use of liquid chemical sterilant processing system, or repeat high-level disinfection. And FDA encouraged healthcare facility to implement one or more of those options. Also, as a result of FDA work, there was a corrective action on TGF-Q180V scope with voluntary recall and replacement. There were changes in instruction for use with annual inspection of elevator forceps mechanism, as well as new operation and processing manuals were issued. So where did it leave us is what I call confusion, uncertainty, and havoc. And that is reflected in the survey where I believe almost 250 centers that perform ERCP were asked what of those four measures, which ones are used. And then majority, as you could see, 90%, almost 90% were using supplemental measures, with most of the centers using repeat high-level disinfection. And then also second most commonly used was microbiological culturing. What's also important is that less than half actually was used manual forced air drying, and I'll explain later why it's important. Very few centers were routinely screening for multi-drug resistant organisms. And half of the responders, who most of were physicians, felt that duodenoscope redesign is the best long-term solution for this problem. So where are we in 2019? After implementation of FDA supplemental measures and improvement in processing techniques in 2015, there was initial decline in the number of medical device reports. It went from 250 in 2015 to less than 100. However, in the latter part of 2018 and the beginning of 2019, there were again increased to more than 200 reports. There were 45 reports of patient infection, and 3 deaths were attributed to duodenoscope related infection in 2018. So the problem has not gone away and is still there with us. I also put here a recent review of the past decade number of publications and number of cases described with duodenoscope-associated infection. 16 outbreaks were reported. Only 2 of them were related to, one to colonoscope and one to the gastroscope. Various countries, US, UK, France, Germany, Netherlands, and China. Causative organism, not surprisingly, Pseudomonas, E. coli, Klebsiella. And during the analysis, authors felt that contributing factors were such as lapses in the reprocessing, biofilm formation, endoscope damage, and overall endoscope design. I want to go over main outbreaks and what were the lessons that were learned from them. This is from outbreak in LA that happened in 2014, 2015. 15 patients were exposed, 8 was active infection, 7 colonized with a CRE organism. There were no bridge in endoscope disinfection process has been found. And what is commonly found that implicated duodenoscope did not grow any bacteria, but was temporarily associated and believed to be the cause. The time to infection, active infection development was about months and a half. And it's very important that 3 colonized patients cleared infections spontaneously over time. They looked at the factors that contributing to the CRE transmission, and the main factors after adjusting for presence of cholangiocarcinoma were, not surprisingly, active inpatient status, antibiotic exposure, and biliary stent placement. Now, in Seattle, one of the major outbreaks happened in 2012 to 2013. 32 patients were infected. At that time, they had 8 duodenoscopes. After evaluation of those endoscopes, although all the endoscopes were functioning normally, 4 of them actually required critical repairs. 2 had cracks in the biopsy channel. And during initial evaluation, there were no correlation with individual duodenoscope, individual endoscopy staff, no breach in the reprocessing process, as well as no environmental culture positivity, or washers were cultured and also were not positive. What they did to terminate the outbreak, and that they instituted a very extensive endoscope culturing and quarantine process. I just wanted to sort of put a picture of it there. It's actually a 19-step process, requires, I believe, 2 technicians to perform at least. And they acquired 20 new duodenoscopes, and the process was that after the first high-level disinfection, the culturing was performed via that CDC protocol that involves actually 3 technicians trained in sterile culture technique, 19 step. Then after that, the scope was again put in the washer and was quarantined until the cultures returned. During the first year, they had a little bit less than 2% pathogenic bacteria positivity. Importantly, 2 endoscopes required more than 1 repeat high-level disinfection cycle for cultures to be negative. Now, recently, the same group published their follow-up study for additional 3 years after the outbreak, where they had now more than 4,000 cultures. And over time, since they instituted that very rigorous assessment protocol, they were able to bring their high-level disinfection failure rate from, as you remember, they started at almost 2%. They were able to bring it down to less than 0.27%. And for them, statistically significant intervention was withdrawal of one of the endoscope that had high frequency of culture positivity, and they were following new manufacturer cleaning protocols. Interestingly, withdrawal of a second endoscope, as well as with high culture positivity, as well as mandatory device retrofit, did not result in changes. now looking at another outbreak in Netherlands, what were the lessons that group learned from that? And their belief was initially that the main problem was the new model of the duodenoscope with a sealed elevator channel, and they actually did electron microscopy on the scope that was implicated and found small cracks and deposits on both sides. However, we now know that actually every manufacturer and every model has been involved in the duodenoscope associated transmissions, so clearly the answer is not just particular scope model. This is a more recent study from this year that just came out in GIE that's very interesting. It's actually looking at the detailed root cause analysis of a more recent outbreak that they had, and shows how much work and kind of sets up the standard, how the outbreaks should be managed. They had 2 duodenoscopes involved, 27 patients infected or colonized, 10 with active infection, and they actually did a sort of 3-pronged approach. Obviously, they contacted and screened patients as well as lab database search. They actually invited independent auditor who was involved in the first outbreak to kind of evaluate their reprocessing procedures, and they did duodenoscope dismantling and identified 3 issues. There were 3 deviations at that time in 2015 from instruction for use. Elevator was not moved. Mandatory brush at that time, even though required, was not used, and leakage testing was not routinely performed underwater. The other thing that you've seen in previous outbreaks, that there was evidence of moisture and retained debris, and at that time duodenoscopes were functioning without any problems that would have prompted a repair. Now, so we looked at the outbreak where the solution was extensive culturing. We looked at the outbreak, the solution was to change the model of the scope. Now it's one of the first outbreak in Northern Illinois where their solution was to switch to gas sterilization, and they felt that that terminated the outbreak. However, as we all know, gas sterilization has not been FDA cleared for duodenoscope use. Many hospitals don't have it, and it's required a long aeration process. It seems like gas sterilization, though, has been the way to terminate outbreaks. This is a review of another review of outbreaks. As you can see, 6 of them use supplemental gas sterilization to terminate outbreaks. Now, at the end, the main question we want to know, do supplemental measures work? And from Northern Illinois, they actually did a follow-up study after they had an outbreak and they instituted gas sterilization process. They also, in addition to gas sterilization process, instituted microbial culture, but that was a little bit different from the Seattle. They did not quarantine their scopes. They cultured, and they only cultured for CRE. And their defect rate was 1.2%. There were 6 patients exposed, but all were negative for CRE. Now, there's been some data on repeat high-level disinfection, and I wanted to cover it to help us, or at least try to help us answer the question, does repeat high-level disinfection work? It looks like most of us are using it, but does it do anything? This is one study looking at single versus double high-level disinfection, and just to be clear, the double high-level disinfection, what most of us understood it to be, is to be 1 cycle of manual cleaning with repeat automated endoscopic processor washing. And they look at 4 centers, 45 duodenoscopes and linear echo endoscopes, and they saw no difference in growth of high concern organism. This study was a follow-up study to initial pilot that showed the difference. However, in this study, there were significantly lower rates of culture positivity, and authors acknowledged that their study was underpowered to detect difference. And also, they did not follow the CDC, that multi-step complicated culture protocol that is recommended by CDC and FDA. They did not follow. Another single center study looking at single, double, and then single high-level disinfection and gas sterilization. The primary outcome they were looking for was finding of multi-drug resistant organism, and then looking at culture positivity more than 0 and more than 10 CFUs as a secondary outcome. Study closed due to insufficient number of events of primary outcome, and there were no difference in secondary outcome. However, again, double high-level disinfection was not actually double, and it appears to be, and believed by most experts, the second manual cleaning is the most crucial step in breaking the biofilm, and that's what gives repeat high-level disinfection. That part is what's beneficial. And Dr. Motusami, who is an expert in duodenoscope reprocessing and duodenoscope-related infection, wrote an editorial illustrating, and he put it very clearly, and I want to show it to you here, is that this study illustrates many challenging performing research in the field. Despite the fact that it was randomized design, unlikely change current practices and doesn't provide us with clear paths forward regarding the direction of future research efforts. So that is our issue, is that the data as of right now is unclear, and most likely what we believe to be repeat high-level disinfection is not exactly what works. And for it to work, you have to consider following the true double high-level disinfection, which includes manual cleaning, automated reprocessor, wash, then taking it out, manual cleaning again, and again reprocessing. At this point, we are following FDA previously issued safety communication. The most recent one is in April of 2019, and it still recommends using one of those 4 measures, including repeat high-level disinfection. So until, the way I see it, until something is different, that is what we need to follow. Now, the next step is, how do we know that with all that effort we're actually doing a good job? And this interesting studies, or summary of interesting studies, were actually using a borescope, a small scope that goes inside the duodenoscope channel, and kind of asks and answers the question, what do we find there? And the worrisome part, that we find a lot of things there. Highlighted is, in one study, fluid was found 95% of the time, included cloudy. There was, in half of the scope was found, and it seems to be rate between 20 to 40%. We find retain fluid within the channel of the scope after the high-level disinfection. And that is what leads to biofilm formation. Biofilm is the enemy. And what we're talking about, not just debris, but what I think the good analogy is for the kind of biofilm that is very established. It's almost like an onion skin. You have these layers and layers of biofilm, and that's where bacteria can form and retain, and also could lead to falsely negative cultures because it's within the biofilm. Is there anything that could be done to prevent biofilm formation or decrease risk of it. One way of doing is the additional air drying within the channel. And this study actually looked at manual versus automated air drying with a kind of a machine that does the automated air drying after the scopes underwent high-level disinfection. And then they used the borescopes to look inside to confirm that there was no residual fluid, and then as well as ATP testing on the working channel. And they had a significant more fluid droplets with the manual air drying, and there were, with automated, there was no fluid droplets after 10 minutes. Pushing this even further, if ideally having an automated drying storage is probably one of the best solutions, demonstrated another study demonstrated that internal channels would dry at 1 hour versus residual fluid at 24 hours with standard storage. The rate of microbial growth was reduced as well. The other potential enemy could be a Simeticone. We're all familiar with use of Simeticone as to clear the bubbles, to improve the view, endoscopic view. However, all three major GI endoscope manufacturers do not support Simeticone use. It's insoluble in water and alcohol. It's not easily removed with current endoscope cleaning methods. The carbohydrate load in it could be a source for bacterial growth, and the manufacturer recommends use of the lowest concentration and injection through the instrument channel rather than putting into the water pump. There was a study comparing use the lower concentration of the Simeticone and found that with the lowest concentration, you have the lowest chance of having the droplets. Now, we talked about all this time about duodenoscope, what about the US, and the results are similar. You do have a rate of positivity. This is a single study, center study that again showed similar rates of positivity. It's probably lower culture positive rates to the duodenoscopes, but it's there. The good news is that if you are considering using gas sterilization, this is, I believe, in a so far abstract form, multi-center 2-year study of high-level disinfection versus high-level disinfection plus gas sterilization, looking at or addressing the concern whether the image, echoendoscope image, would be affected with the use of gas sterilization. But so far, it does not appear to be the case. So putting it all together and trying to answer the question, what is the reprocessing practices failure rate? In 2016, we felt that with vigorous method of possibly culturing, high-level disinfection, possibly culturing, we could achieve a really low, less than 1% rate of reprocessing defect. However, more recently this year, the results came from FDA post-marketing surveillance studies that FDA actually required each duodenoscope manufacturer to conduct to determine the real-world contamination rate, and also look at if the staff is able to understand and follow manufacturer processing instructions. And unfortunately, all three manufacturers had similarly higher than expected contamination rate and failure to understand the instruction rate. In particular, here the rates of high concern organisms, 5%, and then more than half the time, staff was not able to sort of perform critical tasks or follow the instruction. So that brings us to August of 2019, and quoted from Dr. Castamania's editorial on the subject came a bolt from the blue, and that is FDA safety communication from August of 2019, where recommended hospitals and endoscopy facilities to transition away from fixed endocap duodenoscopes to those with newer designs, and to facilitate or eliminate the need for reprocessing. And FDA clearly stated that they understood that full transition will take time. They also clearly stated and recommended that we should be all instituting a quality control program that includes sampling and microbiological culturing of the duodenoscopes. So that's where we are right now. In the next couple of slides, I just wanted to show you just most recent developments. This is a study from this year at GIE looking at a novel organ plasma activated gas. That is a low temperature sterilization technique. In the bench study, of luminal biofilm of all the sort of superbugs here. After 9 minutes of application, there was a dispersal of both 24-hour and 48-hour biofilms of all 3 bacteria. There were no regrowths. And what is more important, there were no damage to channel material, and actually did not require a long aeration process. There was decrease in ozone concentration in 30 seconds. So this is something to look forward to. Now, just came out, again, a bench study of a disposable, completely disposable duodenoscope, comparing it to 3 models of reusable duodenoscopes, assessing 4 different tasks by 6 expert endoscopies, and having it to be similar in most of those in terms of the task completion times, performance scores, and tip control. There was slightly lower navigation and pushability ratings. This is really, I couldn't find a lot of information or practically no information on this. It just got FDA approved several weeks ago. Scope Seal, it's a endoscopic contamination prevention sheath. It's single-use disposable. It's compatible with Olympus duodenoscope, and includes a proprietary working channel extension element that provides an additional prospective barrier in sealing duodenoscopes' hard-to-clean elevator surface areas. So very limited data so far. And the question at the end, how much is it going to cost? Well, clearly it's going to cost a lot. The cost, this is from data from Illinois, the cost of establishing the gas sterilization program was almost $100,000. The cost of processing in the reprocessing culture registry was almost $70,000. And looking at cost effectiveness analysis on several approaches, FDA standard, culture and hold versus gas sterilization versus no RCP. Culture and hold was only cost effective if the pretest probability of CRE was more than 24%. So clearly the big changes are coming, but we're not quite there yet. In the meantime, we should document. Reprocessing protocol, training records should be semi-annual by AGA guidelines, possibly certification. It's very important that there is a way that endoscope could be in some way connected to the patient on whom it was used. Supplemental measures, as of right now, not perfect, but it's all we have. Clearly, FDA recommends us to institute culture sampling. Additionally, air drying during storage could be considered. Cymeticon use should be minimized. Routine endoscope checks should be instituted, and we await FDA pre-market review of ATP strips to assess if adequately validated and labeled as a test of duodenoscope cleaning quality, and FDA advisory committee meeting recommendations that are planned for late of 2019. Thank you so much.
Dr. Reicher, one question. Have the detergents used and tried which could decrease a biofilm?
I have not seen that. I did not see data on that.
And ATP testing, many institutions do it, but what's your feeling? Does it help or not?
So the issue is we're in a difficult situation with ATP testing. I'm glad you brought it up. In that both from the blue, which I would recommend you guys to look at, is that safety communication from the FDA. They actually specifically said in that as of right now, there is not sufficient data on use of ATP as a check for quality of duodenoscope cleaning. That's why they recommended to the ATP manufacturers to evaluate and present post-marketing studies. So until that is done, we use it, our institution use it. I think it's a good thing to continue use it, but we have to realize that we do not have data to support its use as of right now. I'm pretty sure it will be coming shortly, but that's where we are right now.
You mentioned that double cleaning does not really help, but if you do manual cleaning in between would help. Would you recommend that?
This is something that has to be considered. Here's where we are right now. Supplemental measures are still recommended, and double high-level disinfection is still recommended by FDA. The way I always see it, if you don't know what to do, follow the law. So FDA is our law. As of April of 2019, that is what it recommends to do. However, they don't make it easy for us because they don't specify what is double high-level disinfection means. In reality, and it's based on expert opinion, not the data, is that manual cleaning followed by automated reprocessing, followed by manual cleaning, and again, automated reprocessing is probably what disrupts the biofilm most, but it is labor intensive. And it's going to add additional time to your duodenoscope processing, and that's each institution should evaluate what it is. But it's entirely possible that doing like we all doing it, just pushing the button on the washer and doing it one more time, it's most likely, although the data is quite flawed and the studies were underpowered, but it's probably not going to do it.
One more question regarding culturing. So how would you culture? After each use, or once a month, once a quarter?
Right.
What would you recommend?
Again, the FDA does not give us any guidelines on that, except that we have to follow the CDC protocol, that multi-step protocol. They also require having minimal of 2 technicians that are trained in sterile techniques to perform it, because it needs to be, one needs to be sampling and the other needs to be doing additional tasks. So it's quite labor intensive. From what I read, there are different ways how centers do it. The most expensive way is to culture and quarantine. And that requires a lot of additional resources to make it happen, and I think will not be possible for majority of centers. Alternatively is to culture usually what people do is to culture half of their sort of set of the duodenoscopes 2 weeks and the other half 2 weeks, and not necessarily quarantining it in between, just for surveillance purposes.
Thank you very much.
Thank you.